Ladies and gentlemen, thank you for joining the Breast and Cervical Cancer Conference Call. Your host for today is Julie Campbell. You may now begin.
Good afternoon and welcome to today's webinar presented by MPRO entitled The Breast and Cervical Cancer Control Navigation Program. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you'd like to learn more, please visit cancercontrols.mpro.org. If you'd like to download a copy of today's slides, they'll be uploaded to our website, and again, that's cancercontrol.mpro.org under the Breast and Cervical Cancer section. We're very glad to have EJ Siegel speaking with us today. EJ is the director of the Breast and Cervical Cancer Control Navigation Program, also known as the BCCCNP, and she will be talking with us about services offered through this program as well as how to refer eligible patients. Before we get started today, we just have a couple of housekeeping items. Webinar participants can feel free to submit questions in the chat box at any time during the presentation. However, in the interest of time, we're going to hold these and other questions for the phone line until the end of the presentation. And at this time, I'd like to turn it over to EJ. Thanks so much for joining us today.
Thank you so much. I'm thrilled to be here. I just love talking about my program, so whenever I get an opportunity to do that, I really do appreciate it. What I'm going to do today is just give you an overview of the Breast and Cervical program. As you probably have heard in the introduction, we added a new term in it, and there's a navigation component to it now. And there's been a lot of changes in the program over the past couple of years. A lot of it has been in response to really what's going on in healthcare today. So what I wanted to do was just give you an overview of the different components of the program and what are the different services that we provide to low-income women in Michigan, and then go over the process for referring uninsured and underinsured women. Because even though we have over 600,000 people enrolled in a Healthy Michigan plan, which is phenomenal, there are still, believe it or not, quite a few uninsured and underinsured women out there that really do need services. But to be honest, preventive services just is not on their radar for a variety of reasons. Our goal in the program has always been to assure that low-income Michigan women receive timely access to needed breast and our cervical screening, diagnostic, and our cancer services. And when we expanded our program, the only thing we changed with the program goal was instead of saying we provide the services, we put assure that the services are done. And that gave us the opportunity to expand more into the navigation component of the program, which I'll talk more about in a minute. Let me give you a little bit of history in the program. We have been around in Michigan since 1991. We were one of the first programs that was funded by the Centers for Disease Control, and we are also a very highly regarded program by the CDC. Since 1991, we've provided breast and cervical screening and diagnostic services to over 498,000 women. And those are individual women. That's not counting women who have returned to the program over the years. From 1991 to the present, we've diagnosed over 4,100 breast cancers and over 5,800 cervical precancers. We classify those as SIN 2 and SIN 3, and then we also have some invasive cervical cancers, not as many as the SIN 2s and SIN 3s, which is good because really if you can get that cervical cancer early enough, you really can cure it. And since 2001, we have enrolled into our Medicaid treatment program over 8,400 women. So it's been a pretty impressive program over the years. And we've had our highs in, I think it was 2013, we saw 30,000 women. So when you see now where we're at with the number of women we see a year, you can see why we then changed our focus a little bit to expand the program components. Because not as many uninsured women now required the services in the program to be paid for, but there's still a need out there for the services to be given to them. So talk a little bit about our program history and how we expanded it to meet changing client needs. From 1991 to the present, we had what we call our Component 1, our clinical services of the program, and that's the longest component. And then in 2015, which was the year after the Healthy Michigan Plan went into effect, and we found that the numbers of eligible women for the program are dropping dramatically. We added a navigation service component to the program because what we found was even though the women had insurance, it didn't necessarily mean they were getting services. And then this past year we added, actually it's really the past couple years, but we really refined it more this year for our third component of the program. We call it our Health System Change Organization. And actually that's the component that MPRO is part of, that we funded for the last couple years in doing some system change strategies, which I'll talk a little bit more about. So even though this slide looks really complicated, it's now what we look at as our program components altogether. And what I like about this slide is it talks about each of the components, it talks about each of the strategies, and then the evaluation piece. And that is something that we really worked a lot over the past year and a half. And it wasn't so much the evaluation piece for the clinical services, but the evaluation piece for the navigation services and the Health System Change Organization component. Let me talk first about clinical services. Right now, we provide clinical services. We call them caseload services, and the reason why we call them caseload services is we assign a number of women per agency as a goal for that agency to see throughout the year. And right now we're at 15 agencies. 14 of them are health departments across the state. There's 3 in the UP, and the rest are in the lower part of Michigan. And then there's Carmanos Cancer Institute that oversees Wayne and Oakland counties. And if you can see for fiscal year 18, our goal is to screen 7,000 women. So yes, that's a far cry from the 30,000 that we saw a few years ago. And that is how much the Healthy Michigan Plan has impacted the program. But as I mentioned, the need is still there. So we still see these women. We still provide outreach and recruitment services. We still pay for screening and diagnostic services. We work with them to get cancer treatment. And then we also make sure we do a lot in evaluation. We're very proud of the care that we give the women in the program. CDC establishes performance indicators for the breast and cervical program, and their performance indicators has to do with how timely and how complete is the care that women receive. And I don't remember the last time we didn't meet those CDC indicators. We've met them, I think, for the last 17 years. So we're very proud, like I said, of the care given to the women in the program. And we're also very proud of the fact that we make sure they get timely cancer diagnosis and treatment. And we also have a new survivorship component that we're starting to look at now in the program. The program sees right now what we say are uninsured and underinsured women. I want to take a second and talk about that underinsured because I usually can get calls and they say, well, what do you consider underinsured? And we define underinsured in the program as a woman with high deductible, and that's defined by her. So if she has a $100 deductible and she says, I can't pay that, then she is eligible for the program, as long as she meets our income guidelines. There are also women we've found through the marketplace insurance that there are some diagnostics that are not paid for, or they have to really meet an extremely high deductible. We've had women who've had deductibles up towards $10,000. Which just seems unrealistic to me. But until they meet that deductible, which they never do because they never can afford that, they then don't get the follow-up care. We did not want to put any additional barriers for women in the program to prevent them from getting care. So, like I said, if she's saying $100 is high for her, whereas maybe $300 may be high for another woman, it doesn't matter. What she says is what we go with. The navigation component of the program really has expanded over the past years. You know, for 25 years in the program, when we just looked at clinical services, we had 21 agencies, and that was it. And then over the past years, for a variety of reasons, we've had some of the health departments drop out, but we added 10 additional agencies on to just do navigation only for us. So our clinical agencies, the 15, the health departments in Carmanos, they provide actual reimbursement services through the program, but they also provide navigation services for insured women. But we also approach then other community centers. We approach county health plans. We approach FQHCs. We have a contract with the Michigan Primary Care Association, and we have funded some community health workers for them. So I think we're up to about 13 FQHCs now throughout Michigan. So although we have 25, I call them parent agencies that are doing navigation, we have expanded to probably over 50 individual clinic settings that will be doing navigation for us. So we know the need is still out there. Our goal for fiscal year 18 is 2,000 women that we want to look at for navigation. And actually, I think I set that goal too low because for fiscal year 17 right now, and our fiscal year ends on September 30th, we are already at 2,000 women that we navigated. And that's not even all our FQHCs are on board yet with doing navigation services. So we're going to have to adjust that a little bit next year. So we know the need is there. We know there are a lot of women out there that have a lot of, I don't know if I like the term barriers, but what I like is there's issues, there's problems. There's some reason they cannot get the service. And the easiest way that we explain it to our community health workers, because when I say the term barriers, people think I'm looking at something very global, and really it could be something very simple, as the woman doesn't understand that she needs to get an annual mammogram. With all the confusion that came out last year with the different screening guidelines between the task force and between the American Cancer Society, there are women that said, do I get a mammogram every year, every 2 years? I don't really know this. We have a lot of women with we call our priority populations where language is a real issue among Hispanic women, among Asian women. We also have women who, depending on where they live, transportation is a real issue. So, it's wonderful that women have the access now to insurance, but they still have issues in trying to navigate that health system. They may not have a provider. They may not know what questions to ask in their insurance. So we really feel that the navigation component of the program actually is kind of taking more of a precedent now than the clinical services of the program. And we report this information to CDC so they can have an understanding, too, of what is it that women are facing, even though they have insurance, because it shows the program is still needed. And that's how we then justify our funding. And then finally, the third component of our program we really refined over this past year, and we have 5 separate health systems. And as I mentioned, MPRO is one that we do fund in this component. And what the focus here is to look at evidence-based intervention strategies, and these are taken from the community guide. And how can, within that clinic setting, within that health setting, really look to increase breast and cervical cancer screening rates. So we're working with the health systems in having them choose 2 of these evidence-based interventions. And how can you implement that within your system? What's your process for working with your providers to get this strategy implemented? Because the goal is then who is tracking the care that the women are getting within that health setting regarding did they get their screening or did they not get their screening. And as we know, when women come in to see the provider, preventive services are not on their mind. They're coming in for some other reason. And it's really kind of up to us, I think, to kind of put that little reminder there and say to them, it's really important that you do get the screening, and this is why it's important. And is there anything I can do to help you to get that screening? Okay. So I want to kind of fall back a little bit and talk a little bit more about our clinical services. So I usually get questions as to, well, with, the different guidelines out there between ACS and NCCN and the task force, what does the program really follow? What will the program pay for? And the program has 2 medical advisory committees that are part of the Michigan Cancer Consortium, and one is a breast advisory committee, and the other one is a cervical advisory committee. So whenever there's any change in national guidelines, either myself or the colleague that I work with, Ann Garvin, we come really kind of pull together our advisory committees and present all the evidence that's out there. And these advisory committees are comprised of experts from all over the state. And really what they do is they come up with these recommendations, and that comprises what we call our medical protocol. And to participate in the program as a provider, the understanding is that you would follow our medical protocol and follow our screening and follow-up guidelines. So here's an example. If you would go to the Michigan Cancer Consortium website, you would see the protocol for breast cancer posted, and I have another quick slide for cervical cancer. I know you can't read this, and I'm not going to go through the whole thing. What I just wanted to show you to point out is the protocol looks at screening guidelines from the program perspective for average risk women, but we also have some recommendations for women that are at increased risk for cancer. And this is part of the program expansion that we have done over the past couple of years. Because before we were only focused on average risk women. And now what we found was that there are women that are at increased risk for breast cancer that really have no providers or really have no guidance as to what it is that they need for screening. So we put some guidance there also. For the cervical guidelines, we go by the ASCCP guidelines, and this is just the first page of that. And we have put in here what the screening tests are that we will pay for and also what the follow-up is. I want to take a minute, though, to go through the screening guidelines because this is where I think there is some confusion going on here. Be paying attention to the U.S. Task Force guidelines and ACS guidelines last year. What you'll notice is that there is no mention of a clinical breast exam. And the evidence, according to the task force, was insufficient that the clinical breast exam would really have any impact on mortality in breast cancer screening. When we discussed this with our providers in our advisory committee, they said, you know, we really think we shouldn't drop the clinical breast exam altogether, but we should educate women and providers that the clinical breast exam by itself really is not breast cancer screening. The mammogram really is. But we should make the clinical breast exam be part of what they call a clinical encounter. And I like the way this is worded because it says that this clinical encounter really should look at the ongoing risk assessment, risk reduction counseling, as well as a clinical breast exam. And this is how we then explain to women where there is that and with the ACS guidelines, they don't recommend to start a screening mammogram until age 45. And then we have women in the program that are 40, 41, 42, and they're saying, should I get a mammogram or should I not get a mammogram? And this is where we really guide them to say, what you need to do is talk with your provider. And what is your individual risk? What is your own belief on, you know, regarding what you feel you should or should not do? And what would be your ongoing risk? And then based on that, make a decision. So it's an informed choice, and it's a different way that we're approaching how to look at the clinical breast exam component of this. Because in the past we always said, well, clinical breast exam and a mammogram, that's whole part of breast cancer screening, and that's not such the case anymore. We just have sometimes women in the program who just get mammograms, and then that's fine if they decide they don't want a clinical breast exam. And we have other women in the program who decide they don't want to get a mammogram until after age 45, and that's fine also, as long as they have all the information to make that informed choice. So that's a different term for us because we haven't been thinking that way. What we found over the past year is women really value that additional information because really no one really sits down with them and really takes the time to talk with them about what their risk is. So even though we have the task force and ACS kind of at odds with saying when to start mammograms, we still say age 40 to start, and that yearly exam should continue for as long as the woman is in good health. So like I said, if the woman wants to start at age 45, that's fine also. For cervical guidelines for screening, we don't screen women under age 40 in the program for cervical cancer. We do follow up mostly for that, and I'll talk a minute more about that. But for our program, we see women 40 to 64, but we do go by the ASCCP guidelines. So for women aged 21 to 29, it would be recommended that they have a conventional Pap test or liquid-based cytology every 3 years. No HPV test is recommended for women in this age group. because the thought is, and actually it's probably correct, most women in this age group already have HPV. So you're not going to do anything different when you find that out. And usually what happens in this age group, when the woman's healthy, it regresses on its own. For women aged 30 to 65, there are two options. Either we do an HPV with cytology co-testing, that we call it. That's what's preferred, and that's every 5 years. Or a conventional Pap test or liquid-based cytology every 3 years. So either one would be fine within the program. So now, who all is eligible for breast and cervical? I talked about we expanded some of our guidelines. The income has not changed. That's still, the woman has to be less than 250% of poverty. To give you an idea, that's less than $40,600 for a family of two. For age, though, this is where we did some expansion. Before, we always said 40 to 64 and requires breast or cervical cancer screening or diagnostic services. But 2 years ago, we expanded that. For about 15 years in the program, we had we still do, a collaborative partnership with Title X, Planned Parenthood, and Family Planning. And we said that if they identified women under age 40 within their clinics that had an abnormal Pap test and she had no insurance but met our income guidelines, they could refer her to the program to get follow-up. But we only took women from Title X. Well, 2 years ago, we expanded that. So now we take women 21 to 39 who have an abnormal Pap test or an abnormal clinical breast exam or an abnormal mammogram from any provider. So she either feels a lump or she gets sent for an ultrasound or a mammogram, there's something abnormal, or her Pap's abnormal from a private provider. She meets the income guidelines, we will take her in the program, and we will provide a diagnostic follow-up testing for her. And actually, to give you an idea, for women 21 to 39, most are in their 30s. We did have one in their 20s, but we've diagnosed probably about 15 women then with breast cancer, early breast cancer in that age range. So, like I said, my colleague and I, Ann Garvin, we're thrilled we expanded this guideline because we knew those women were out there, but we just couldn't see them before, and now we're glad that we can. To be eligible for the clinical services, the women need to be uninsured or underinsured, and I talked about that earlier. She needs to be a current Michigan resident. What we mean by that, she needs to have a Michigan address. But we do see migrant workers in the program. And then because Michigan is what we call a border state, because we have Indiana, Ohio, Wisconsin, Minnesota around us, if the women are living near that border but they plan to receive services in Michigan, then they're eligible for the program. So how do you refer women to the program? Well, we have a couple of ways of doing that. I have our website listed here, and I have a screenshot of a PDF document that you can download and print off. It lists all 83 counties in Michigan, and then it also lists the coordinating breast and cervical agency. So one of those 15 agencies will cover they cover 83 counties. We have some agencies that cover 10 counties, some agencies just cover 1 county. But we do have a contact phone number there and who to call and regarding whatever county the woman lives in, so we can get her to a provider that's pretty close to her in that county. But if you can't get that information down, then I recommend you jot this number down. This is our new 800 number, we call it, 844, I got screened. And we have that now in all our promotional materials. Matter of fact, we're going to be doing a big media splash. Actually, it's coming up in June. It's coming up in a couple of weeks. So you may be hearing some information. We're going to do it in different markets. But this is the number that we are promoting. This number actually comes right here to us at the State Health Department, and it goes right to one of our lay navigators, Tori Doney. You can leave a voicemail. The woman can leave a voicemail message, and we will get back to her within a day, or sooner. And we can then refer her to the nearest agency and get her services that she needs. So what services do we cover? Well, those have been expanded too over the last few years. Before it was just some screening and some diagnostic services, and then as technology has changed And of course, we can only cover what CDC will allow us to cover. But we've done some lobbying with CDC on some tests. And CDC's become more lenient also in the last few years, because what they said was there are some that really are not really on their cost reimbursement schedule. But if your medical advisory committee says that in a certain situation this test should be covered, then we can cover it within the program. So we've always covered mammograms and ultrasounds, looking on the breast services side. What I want to talk about ultrasound is we cover diagnostic ultrasounds. There is no CPT code for a screening ultrasound, but ever since Michigan passed its breast density law a few years ago, what we're finding is that almost the mammogram and the ultrasound in some areas are like a package deal. So if the radiologist is seeing something, some density on the mammogram, then he'll automatically order an ultrasound. We'll pay for the both at the same time. We don't consider that ultrasound screening, but we will pay for that. A new little guy on the horizon there is tomosynthesis for 3D imaging, and that is added on with the mammogram. It does not replace the mammogram, and we do cover tomosynthesis. MRIs and ductograms, we've just started looking at covering those the last couple years, and you can see it says MD-HHS authorization. And usually, and I'll explain to go about that, but those are the cases we look at on an individual basis to be sure that it's going along with our medical protocol. There's very few that we would deny, and like I said, the majority of these we do approve. We do pay for all the biopsies with anesthesia with an excisional biopsy, office visits and surgical consults, and then a new guy coming up, genetic counseling and testing, and I'll talk more about that in a minute. On the cervical side, as I mentioned earlier, we pay for Pap tests and HPV, but we do now pay for urine tests, pregnancy tests. We bill with colposcopy services. We could not pay for those in the past, and a lot of colposcopists they do. They want to make sure she's not pregnant, and they're doing the colp. So yes, we do pay for those now. Pay for the colp and ECC. And then you'll see we have another authorization, diagnostic lead, diagnostic cone, or an endometrial biopsy. And again, I'll talk more about that. So how do you obtain authorization if you have a client you want to refer? The easiest thing to do is to contact the local breast and cervical agency that you're affiliated with. And we just need we call it our justification for why the provider wants to order the service. And that's what we'll ask. You know, a lot of times Ann will get a call and she'll say they want to do a diagnostic lead. And I'll say, well, what's the Pap test result, and why do they want to do this? And again, we're just looking to see this is in line with our medical protocol. Genetic counseling, I mentioned a minute ago. We were very, very fortunate in 2014 that one of the senators lobbied before he left office for a breast cancer awareness license plate. And money raised by that was to help support the breast and cervical program. Well, when he was starting to put this together, it was starting like in 2012 and 2013, and that's when I mentioned earlier that we were hitting upwards over 30,000 women that were eligible for the program, and we really could have used more funds for providing screening mammograms for women in the program. But after 2014, when our numbers dropped, we didn't need the money from the place for screening mammograms. But the way the law is written, it says this provides services for women in the program. So we opened up the door to genetic counseling. And actually, Ann is, this is her baby here. She oversees the referrals for the genetic counseling and for the testing. And we are just thrilled about this because this is a need in the program for so long. And whenever we'd get a call, gee, this is what they want to do testing on a woman, they want to do counseling, we were kind of scrambling, trying to find counselors that would, you know, see the woman and try and get payment for testing. So this is really great that now we can pay for this out of unlicensed plate funds. So how you know if a woman is eligible to get genetic counseling, we just go by the NCC guidelines. So, and that's what Ann would refer to if you called her. She would go right at the guidelines and say this woman meets the criteria. And really the clinician or the genetic counselor must contact us for approval prior to doing the test. And I really cannot stress that enough. because we only do the test, the BRCA test, and we don't do the 21 assay panel. We only do BRCA testing. And we only do that at the University of Michigan. It's the way we have it set up. So we would have to tell you what needs to be done so you can get the specimen there. And actually, I gave Ann's contact number here. She'd be the one for you to call and say, yeah, can I kind of run this by you and see what you think? And she'd be more than happy to help you out there. Or if you want more information, it is on our website, and we have a whole tab devoted to genetic counseling and testing, along with all the forms that you need for referrals and any additional information there. I think to date so far we've paid for, I want to say, 2 BRCA tests this year, and there are 5 different counseling sessions. So it's slowly coming, but it's starting to come. And finally, the last thing I think I just want to bring up here is our Medicaid Treatment Act for cancer treatment, because we are really very proud of this and very proud of the care the women get in this program here. The breast and cervical cancer by itself cannot use CDC funds to pay for treatment. So the problem in the program, and this is like right after I started in '99 that we found, is becoming increasingly difficult to try and find options for women to get, breast or cervical cancer treatment. So in 2001, former President Clinton signed a law before he left office, calling it the Medicaid Treatment Act. And really what it says is a specialized Medicaid program, and it provides full Medicaid benefits for the woman as long as she meets our criteria and Medicaid criteria. And we've expanded this over the past few years also. Before, the requirements for the woman had to be enrolled in the program, receive paid services in the program. If she was diagnosed with cancer, we can get her on Medicaid, and that's not the case anymore. We, because of the changing, with different things going on in healthcare, we have talked to Medicaid, and we're able to open it up to women outside the program. To be eligible, you need to be between the ages of 21 to 64, and your income has to be below that 250% of poverty. And this is probably one of the stickling points here, because when the program first went into effect, as you can see, it was 2001. Medicaid eligibility at the time, I think, was, 52% of poverty. So to expand it up to 250%, we had to jump through a few hoops at Medicaid to assure that we were really going to be case managing these women and trying to get the care that they need. The woman needs to be currently living in Michigan, but there is that border eligibility requirement. And we have had women that if they live in Wisconsin but they want to get their cancer treatment in Michigan, then our Medicaid will cover her. The one stickler here, and this is nothing we can control, but the woman has to be a U.S. citizen, a legal resident, a registered alien, or a refugee. Whereas to get services in the breast and cervical program, we don't ask citizenship status. So the woman could be an undocumented resident, and we would provide her services. The concern then is if she's diagnosed with cancer, then we have to have some other options in place to get her treatment. And all our agencies do have some type of option in place to help. And I think it helps out that the majority of the women now are eligible for Medicaid. The providers aren't so uneasy now to provide care that's not compensated. For insurance requirements, this is something that has really been expanded. Before, it could only be uninsured women, but then now with the changes to the Affordable Care Act and the issue of being underinsured, we found that there are a lot of women out there that they have what's called non-creditable insurance. And what that means is their insurance has limited or no coverage for cancer treatment. In the past, we would have to require the woman to drop her insurance. We don't have to do that. So if she has an insurance deductible that's greater than $1,500, she can keep her primary insurance, and we can add our Medicaid on board with her. The only time she would have to drop her insurance is if it's less than $1,500. The other concern, too, with the program, though, is clients that are under Medicare A and B, they're not eligible for our Medicaid. And that's a federal law. That's something we can't get around. One of the other expansions to the program we did, we originally had said before the woman had to be newly diagnosed with breast or cervical cancer or recurring cancer, and now that has changed a little bit. So if she has private insurance, like through the marketplace, she's not eligible for our Medicaid if she's already received treatment reimbursed by that insurance. If, however, she knows she has a very high deductible and we find out before she has any treatment or before her insurance has paid for anything, we can then get her switched over into our Medicaid. Women who are on the Healthy Michigan plan or another type of Medicaid, however, though, they can transfer at any time within their treatment. The reason for that is the Healthy Michigan plan, after you've been on the plan for 6 months or so, you start getting copays added on to, like, doctor visits. There's cost sharing. I know there's copays for drugs. And our Medicaid, like I said, the special Medicaid is still fee-for-service, one of the few left. So I don't like to say that too loud. But we have no cost sharing and we have no copayments. And it can start adding up. When you look at a breast cancer client, after about 6 months, she's back and forth to the doctor quite a bit. And then they prorate that based on how much she's using the healthcare system. So we've had women sometimes who are on Healthy Michigan who said, I'm stopping treatment. I just can't go on this. I just can't afford it. And then we were able to switch them over. So we're really fortunate that we can do that. If you have any questions about anyone, my contact information is right there. You can call me. You can call Ann. We'd rather you just call, and we'll see what we can do to help you out. There's very few women I can tell you that we do turn away, or we do have some other options that we can maybe provide to try and get the woman the care she needs. And then I left here my contacts for myself and for Ann, and I also put down Tori Doney's contact as our lay navigator, because there are times if you can't get Ann or I, you'll probably be able to get Tori, and Tori can always either answer your question or she can kind of get a question to us. And then also for more information, there is our website. We also have some brochures on the website. You can order from the clearinghouse. They're free. In fact, we just updated them, so we're going to be getting a whole new batch into the clearinghouse. And you can order as many as you want, and you can give them to your patients as needed. And that's all I have, and I can open it up for questions.
Great. Thank you so much, EJ. At this time, we'd like to make the evaluation questions available to all attendees as well. If you could please take a moment to let us know your thoughts on today's session. We do use participant feedback from these evaluations when we plan our future learning sessions. So at this time, we would like to open the line for any questions that participants might have for EJ.
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. We're currently waiting for callers to join the queue.
All right. While we wait to see if anybody has any other questions, EJ, I did have one for you. At the beginning of the presentation, you mentioned some survivorship activities or survivorship focus. Yes. I was just wondering kind of what activities might be wrapped up.
Yeah, thank you for saying that. We were just starting that this year, as a matter of fact. We have a Wise Woman program. Our Wise Woman program is another CDC program, and it is a program aimed at healthy lifestyles and behaviors. And for the first time this year, for our women that are on Medicaid Treatment Act, we have opened it and select agencies that they're eligible also to participate in the Wise Women program. So this program promotes healthy exercise, healthy eating. There's life coaches that help the women with some survivorship issues. We have put together a web module, to help with the coaches to review what are some of the common, long-term side effects of cancer therapy. So they can, a lot of times, women don't say anything to their provider, but they'll say something to, one of our coaches or to one of our navigators, and then they can get them in touch with the provider who can help them with that. So, like I said, that just started this year, and we're starting to see more and more women take advantage of that. So that's what we're doing right now for providership.
Awesome. Thank you so much for that. We just wanted to check if we had any more questions for EJ from the line.
Again, ladies and gentlemen, if you'd like to ask a question, please press the number 1 key. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Currently, there's no questions in queue right now.
All right. Well, again, EJ, thank you so much for taking the time to speak with us today, and also thank you for all of our attendees for joining us as well. The slides from today's presentation are going to be available on MPRO's website, and a recording of this session is going to be uploaded to MPRO's YouTube channel within the next week or so. So if we don't have any more questions or comments today, that concludes our session.
Thank you very much.
Thanks so much for joining. You may now disconnect. Have a great day.
Thanks.